So my task this morning is to talk a little bit about normal anatomy after bariatric surgery. This is my disclosure slide. Nothing is going to be relevant to my talk this morning. So what I'm going to do is review some of the surgical anatomy and discuss really the relevant features for the endoscopist. And I divided the operations based on some historical operations to get some familiarity with what was done in the past, as well as the more uncommon procedures, but still being performed at a much less percentage in the U.S., and then your three more common procedures, and then some potential investigational procedures that may become more commonplace. And again, just focus on the common findings at the time of endoscopy. And you have to remember, it's pretty uncommon to do upper endoscopy in patients that are not having postoperative symptoms. So always take that in a grain of salt. So the GI bypass, this is something that many of you probably are not very familiar with, because this is an operation that was really abandoned more than 2 decades ago. But this operation is still occasionally being seen. I probably see at least one of these patients every other month. And that operation, if you do a workup for them, you have to remember the anatomy looks very similar to what's depicted here. There is no gastric intervention. You'll have either one or two anastomoses. The anastomosis that is going to be distal to the ligament trites is going to lead straight into the ileum, and then the defunctionalized limb or the limb that's no longer in circuit can sometimes be anastomosed either to the transverse colon or to the right colon or to the transverse colon. Again, this operation is a historical operation, so it's be pretty uncommon for you to see this. Gastroplasties are probably one of the more common operations that require revision, and there was a number of different operations that were done. The horizontal gastroplasty is depicted here, where you can see a staple line or a suture line that goes from the lesser curve towards the greater curve, or vice versa, or a staple line that comes from both with a middle outlet, or known as the Gomez procedure. This operation, again, endoscopically, as you can see depicted here, is going to look essentially like this. There is no intestinal manipulation, and the outlet may be in various areas, and the outlet may be reinforced. The mini gastric bypass, this is a procedure that in pockets throughout the United States is somewhat more common. This operation essentially has a gastric manipulation where there is going to be an anastomosis, essentially what looks like a Billroth 2. You're going to have both an afferent and as well as an efferent limb. The hallmark of this operation is going to be bile within the gastric portion, and then going to be two separate lumens as well. It's very common. If you see this, the anatomy you may identify patients that have marginal ulceration, particularly at the anastomosis, as well as significant alkaline, both gastritis as well as esophagitis. This operation is an uncommon procedure, but still is commonly seen. This is a vertical banded gastroplasty. This operation has, again, only gastric manipulation. As depicted here, it's a compartmentalization of the proximal stomach based on the lesser curve, again, done in the 80s. And more often than not, this is something that with an inexperienced endoscopist will typically call this a hiatal hernia. And what they'll see is they'll see an impression further down distal, and they may see a potential stricture or a banded area, and then a disrupted staple line. So disrupted staple lines were as common as 30 to 50%. And again, there is no small bowel anastomosis. Vertical banded gastroplasty, this is just a quick little video. I know I'm really supposed to talk about the normal, but again, it's pretty uncommon to find normal things. This is basically looking at the proximal stomach. If you were to have a VBG, more often than not, they dilate quite a bit, and you may see something like this. This is a piece of Marlex that was used as the banded outlet, and here we're trying to remove it endoscopically. But the normal anatomy would be a very dilated proximal stomach with possible staple line disruption. These are the three common operations that I really want to focus on and what they look like, and I'll break them down independently. So the gastric bypass, as we all know, has both a gastric as well as an intestinal manipulation. The operation is really based on the proximal stomach, based on the cardia. There is typically no communication with the body or the antrum. The proximal pouch is then anastomosed to the small intestine. More often than not, the stomach again is based on the lesser curve, and the operation today, if they're done laparoscopically, more often than not, they're going to have a separation between the pouch and the remnant. So you should not see bile within the gastric pouch. If you see bile within the gastric pouch, you have to worry about either a gastric fistula. A lot of times you will also see marginal ulceration or potential foreign body. So that's the typical appearance on this schematic of what the anatomy should look like proximally. And this is what it should look like endoscopically. So again, as you go down into the esophagus and to the stomach is going to be isolated based on the cardia. This is us getting into the gastric pouch itself. And you should, again, not see bile within the gastric pouch. The anastomosis is more often than not going to have a blind limb, or also called the candy cane as depicted here, and then the roux limb that goes downstream. The anastomosis is going to vary from procedure to procedure, but typically is going to be less than 2 centimeters in size. And this is what it would look like radiographically: esophagus, the gastric pouch, the blind limb. On this imaging is towards the left side, but again, you can have it towards the right side as well. If you do a contrast study, you're not going to see contrast, hopefully, in the gastric remnant unless it is refluxing all the way back up or there is a fistula. This is a endoscopic view of a dilated anastomosis. And I think more often than not, if you're going to be doing endoscopy post gastric bypass, this is what you really need to be looking for, is potential failures of the operation. This right here is a dilated gastrojejunal anastomosis, as well as a little gastric fistula, and this was depicted by having bile within the gastric pouch. This was in someone that had an open gastric bypass, and again, you have a higher staple line failure rate between the pouch and the remnant, and we eventually ended up doing an endoscopic procedure. Strictures, I know there will be a talk about strictures, but I want to kind of just highlight the difference in the anastomosis of the gastrojejunostomy. As you become more experienced in doing these, you'll recognize what is a normal and an abnormal anastomosis, but more often than not, the best tool is your endoscope. If you use a standard diagnostic endoscope and you have difficulty in passing that endoscope through the anastomosis and the patient has the typical symptoms, then more often than not we consider that a stricture. And you can see here the difference in the size. This is clearly difficult for the endoscope to pass through when we do a CRE balloon dilation. The adjustable gastric band, and what does that look like endoscopically as well as radiographically? This is a procedure as depicted here in all these diagrams. You can see the upper GI appearance of what the band should look like in relationship to the spine, what it looks like laparoscopically. What does it look like endoscopically is a little bit more of a challenge. I think this operation or this imaging typically is more seen on upper GI, but this is typically what the band would look like. You would have the gastric pouch. If the band is overtly tight, you may have a hard time going across the actual band itself. Remember, it's only a gastric manipulation. On retroflex views, it looks very commonly like a Nissen fundoplication. So this is what it looks like on retroflex views. What you need to make sure you look for are gastric band erosions. That's what you want to keep an eye out for. And then anterior and posterior slips. Anterior and posterior slips, you can see that on endoscopy. More often than not, above the band itself, you'll see a pooling of fluid as well. And this is obviously abnormal findings. And so on retroflex views is probably the best way to look for an erosion. And obviously if you see something like this, then you know that's an abnormal finding. Sleeve gastrectomy, this is probably one of the more common operations in the last 5 years that we're performing. Obviously this operation is only a manipulation of the stomach itself. With this operation, you're essentially removing the greater curve of the stomach. The actual configuration of the sleeve varies quite a bit from individual to individual. So you may see something that is a relatively straight tunnel, or you may see things that are somewhat tortuous. But essentially, as you come across the esophagogastric junction into the stomach, it's going to be based on the lesser curve. You're going to see the antrum and the pyloric channel as normal prior to surgery. So again, it's only gastric manipulation. Here you can see the pylorus, and as you come back up, this is actually an intraoperative view, so it's a little bit more hemorrhagic, but typically the staple line is going to be 4 to 6 centimeters. If you have a oversewn staple line or an invaginated staple line, you're going to see it look just like this. This right here is the incisura angularis. That's probably the most critical part of this operation, that and the angle of His. But you can see all this folded up tissue that is within the gastric lumen itself. And that's what it's going to look like endoscopically. When you go back and later time look at these patients, a lot of times that folding will still be present. So the endoscopic view is typically like that. Remember, again, the pylorus is intact and there's no anastomosis. You may see suture material as well as staples endoscopically. Radiographically, it's going to vary based on the configuration of the stomach, but essentially what you should see is the esophagogastric junction in its normal anatomic position, the sleeve itself, the incisura as it comes around, and a normal appearing antrum and pylorus. The CT scan should essentially show contrast filling the entire gastric remnant. This is an abnormal view of a gastric sleeve. This is a CT scan reconstruction, and what you see here is a lot of pooling of proximal material. As you're taking the endoscope going down, you can see there's no true outlet obstruction. However, there is an acute angulation. As you can see, as we navigate through the stomach here, it takes a very an abrupt right turn. So if you're having to really manipulate the endoscope in one direction, such as depicted here, and you have this proximal stasis, you may have an acute angulation or an acute turn at the incisura angularis. Looks like we have a little stop in the slides. Can you guys advance the slides there in the back? Nope.
Well, Bipan, while we're waiting for that to load, can you give us some insight for your gastroenterology colleagues? How much education do you have? Because very often we may not be scoping our own patients, or the patients may come in when we're not around, and one of our GI colleagues has to scope the patient. How familiar are they with this anatomy, and where do they kind of fit into the picture?
Yeah, that's a great question. I think you know, if it's a gastroenterology colleague that works at your own institution, I think it's probably prudent for the surgeon to at least identify 1 or 2 people in their institution that they can really rely on if they're not going to be doing their own endoscopy. And the biggest reason is so they can get really familiar with what the normal anatomy looks like, because they probably see more often patients that are symptomatic and have abnormalities. So, you know, for most gastroenterologists, I think the familiarity of gastric bypass is much more common. I think sleeve anatomy is probably less common just because it's a newer operation. So for gastric bypass, I think it's very common, but I think what you need to do with your gastroenterologist is really talk about the timing of the operation, what's normal, what's abnormal, when should you dilate, how high should you dilate, what if there is a marginal ulcer, what else you should be looking for as far as etiology. So I think the familiarity with the gastroenterologist, I think it's really the job of the surgeon to identify 1 or 2 gastroenterologists in their own institution that can really be kind of the champions, if not yourself. And I really believe that the surgeon should be doing this more often than not. The last procedure is more of an investigational procedure, and again, this is going to be in pockets throughout the country. This is in a gastroplication. Again, this is gastric manipulation only, and this is infolding of the greater curve of the stomach. There's typically several rows that are placed. It can be either individual rows of sutures or a running suture line. And again, you should see essentially the pylorus intact and a normal small bowel distal. Endoscopically or laparoscopically, this is what it looks like. It almost it mimics the sleeve, but remember the laparoscopic view is really not doing justice to what the plication is. Endoscopically, this is what things are going to look like. What you should see is this almost, if it is a greater curve plication, this half of a C type of configuration. Again, the same areas of obstruction are going to be either at the incisoriangularis or the proximal stomach. What you want to look for is this healthy appearing mucosa. There's been several reports of ischemia of the stomach itself. So endoscopically, a normal appearing plication is going to almost look like a very thick sleeve that's been invaginated, and you're looking for normal, healthy mucosa. That is all I have. Thank you very much.
There is a question from the audience, Bipan. What are the tricks to adequately size the GI endoscopically, and what is the upper normal?
So I assume this is about the anastomosis, the GJ anastomosis. Well, what are the tricks to looking for an appropriate size? I think our goal of the operation is try to get an anastomosis that's greater than 1 centimeter in size. So more often than not, a standard endoscope that typically is between 9 millimeters to about 1 centimeter, that should be the minimal diameter of your anastomosis. So if your endoscope can pass through, then it's an appropriate size. The upper limit is a little bit harder to appreciate, and I think you have to use some type of a tool to help measure it. My common tool that I use to measure my anastomosis is typically a snare. And what I typically do is I'll look at the anastomosis, I'll try to see if it's an oblong type of an anastomosis, which is more often seen in a linear anastomosis versus if it's more of a round anastomosis that we see in circular. Then I'll choose the snare based on that. And the good thing about snares is you have various different sizes of snares. You can go from a 10 to a 15, a 10 round, a 15 round to something that's greater in diameter. So more often than not, you can start to eyeball these and get a pretty good idea what the size of the anastomosis is, and then you want to confirm that. And so I typically use a snare for more often than not. For most of those, you can use biopsy forceps as well, but I think the snare is probably the easiest one to size your anastomosis. So look at it, get an idea what do you think it is. You saw a couple of the clips that had a 15 millimeter oblong snare. That's probably the most common one that I use. If you're worried about a very large anastomosis like that 3.5 centimeter anastomosis, there are snares that go up to even 4 centimeters. You can choose that, open up the snare. You can a lot of times manipulate the snare where it lays just on top of it and then take some imaging because that's what you really want to look for, see what's normal and abnormal.
Thank you very much.
Thank you.